idea of the network just sort of redefined and redone 2.0. We got a big thunderclap, but that was pretty.
That was like
I don't know if that
God saying something. I don't know what we did.
Like, I swear,
yeah,
Blue
we
Cross,
didn't mean to.
Don't
Lightning
come
will
down on me.
strike.
No, it's fine. We definitely need the rain. So Blake Allison, why don't we start a podcast,
Sure.
man? Let's not make it awkward. Well, good to see you. Thanks for joining me on the show, man.
No, thanks for having me. It's good to be here.
Yeah, and cool that you were able to kind of be a sub last minute, and not to say that this won't be interesting, but we just logistically had to make a last minute change, and you were able to fit this into your schedule. What brought you down to Dallas, though?
Yeah, well, first of all, it's okay to call a sub. After looking at the guests you sent me, I realized that you definitely got to the end of your list and then found me. So it's
self-deprecation is my style too, so I like it. We're already hitting it off, man.
I'll thank Madeline that she had to bow out and then gave me an opportunity. So yeah, it was great that it worked out. It was kind of better to be lucky than good. Where say, can you be here on Thursday? And happen to be flying in already from Florida. So yeah, it's a privilege. It's fun to talk about healthcare, and it's fun to talk about what we're trying to do. So I'm glad it worked out.
Yeah, we got some sports talk in there as well. Maybe we'll include the sports talk in the front. It's always fun to get to know somebody, right? It's like where are your connection points and stuff like that when you meet them for the first time. So you're in from South Carolina, in here for business. Appreciate you fitting me in your schedule. Everything going good meeting wise? And
yeah, I think so. Yeah, so it's always I'm a native Texan, I think, as we talked about. Yeah. So it's always good to be somewhat home in some ways, and yeah, everything's good. We're trying to, as a young company, just find the things we need to do to get our footing. And what hurt us a lot was COVID put a lot of pause in a lot of ways, but it also put a lot of pause in the relationship side of what we do. And this is a relationship business, and so by being able to travel again and get around and sit down with people and really understand and listen to what they're doing. There's a football coach for my favorite team that says listening can be a superpower. And I think COVID sort of found a way to do that. So it's been fun to get back into the space, get in front of people. One, just understand who they are and what makes them tick. You're not distracted on a Zoom call. Not that we're all distracted on Zoom calls, but you're able to listen.
Slack notifications are coming in. You got
a lot of emails popping up.
You got the internet at your fingertips right now. I get it. So to your point, we had our VP of Client Services. She's kind of manages the rollout and implementations with new clients and stuff like that. And we had one client that was sort of inching along. Then she finally got on site with them, and it was night and day difference. The rapport that was built, answering questions. All of a sudden, they had the light bulb moment of why am I delaying you? But it was just because we got on site, right? And I think that's really there's something so dynamic about in person. That's why I dedicate the podcast to in person rather than virtual production, because it's just being in the same room as another person and building that rapport. I didn't introduce who you are though, as the CEO of Employers Health Network, EHN. I think let's at least sprinkle that in before we get too far. Did I say that right? Employers Health Network.
Employers Health Network. Yeah. Go by EHN.
EHN. And so we're going to talk networks. We're going to talk value-based care, narrow network to a degree, complementary to RBP, setting up a localized network, things like that. But Blake, we started down this path, and I want to keep going a little bit of like who you are, right?
Sure.
You mentioned growing up in Texas. Where'd you grow up? How long were you here? And then what took you out of the state?
Yeah, so born and raised in Texas, actually born out in West Texas, in a little town known as Abilene. And then we kind of moved throughout the state, but did most of my growing up down in Corpus Christi, so on the coast. And that really, I think, influenced a couple of different things. One, just really huge passion to be outside, and whatever that may be. But Corpus Christi being kind of a coastal town, you're out a lot. The weather's good, and we moved there from Amarillo, which is not that type of town because it's very cold. And so just grew up hunting, fishing, being in sports, doing all that kind of, doing those kinds of stuff. And then, we moved to Dallas when I was in high school. And so then graduated from high school up in this area. But yeah, it just, I think growing up in that environment, I think one, it brings that relational aspect because you're out doing stuff with other people all the time and things aren't happening a certain way, but also just, I really enjoyed sports and being outside. And then got into healthcare and was here doing most of that work inside Texas, and then just had an opportunity, kind of out of serendipitous, and it was one of those moments where the recruiter called me when I was sitting in an hour and a half of traffic. Yeah. And they said, we've got this incredible opportunity to work with some health systems out in South Carolina to do value-based care, which has really become, I think my happy place in healthcare. And so got to move to Greenville, South Carolina. And, being a native Texan, I never stepped foot in the state of South Carolina, and said, let's do some Google work on that. Yeah. And, it was a nice change. And so we packed up the family of 5 and went out there and when I took the job with EHN, we moved our offices to Texas, and I said, well, no, we have a chance to go back. And my wife looked at me and said, you can take this job, but only if they know you're not moving back to Texas.
Oh, interesting. So she became a South Carolina transplant, huh?
This podcast is brought to you by True Captive Insurance, a premier medical stop-loss captive for employer groups ranging from 25 to 1,000 employees. True Captive believes in healthcare that is personal and insurance that isn't complicated. That's why they take a white glove approach, making it easy for employer groups to transition into a program built specifically for them. Check them out at truecaptive.com. This podcast is sponsored by PlanSite. PlanSite is a technology for employee benefits brokers to more efficiently manage their RFP process for any group size, all funding types, and over 20 benefit lines and point solutions. PlanSite is the only end-to-end RFP technology on the market today. Let's modernize your RFP process together. Check us out at plansite.com.
What was it about life in South Carolina versus Texas?
Yeah, it's an easy place to live, and that's the way I kind of think about it. And when I travel in from being out of town, it's an easy airport to land into, and it's easy to get home, and it's easy to do things on the weekends. And not that places aren't, but I didn't know what that meant until I lived in a place that is easy. You don't have to have a lot of time spent to do activities because everything's fairly close and fairly close by. And it also had a kind of a small town feel with the things that are big, though. We have the arts, we have good athletics, we have minor league teams from others, from other sports, and so we can get a taste of going and watching minor league soccer instead of MLS, but it's still soccer. We can watch minor league baseball, so it has this nice blend, and it just became a really easy place to kind of be and to grow up and let our kids kind of see something a little bit different.
Well, so the older I get, like the more I kind of can aspire to that same type of notion that you're describing. Like my wife and I have moved from like downtown Dallas to Frisco, and now we're in Prosper. It's like you start gravitating farther and farther away from the epicenter. You still have access, but you're not in it. Yeah. The quality of life seems to be a little bit higher, the space, the community, all those things. So I totally understand that.
But I still love Texas. I don't want to ever bash my home state. Other than there's oppressive heat.
Yeah,
I landed here, and that was hard for me to. That was the memory I didn't want to have
yesterday, man. And I was like, oh my God, I don't remember the last time it was 106 degrees. And but we make it through somehow every year. Every year, I'm like, why do I stay in Texas in the summer? And then I'm like, oh, okay, well the fall ends up being really nice, and winters are good, and quality of life is high everywhere else except for the heat. You just stay inside.
It is. You just have to run the AC.
You just run the AC at full blast. But so a couple things I want to talk to you about your background that I found pretty interesting, and then we'll get into EHN for the bulk of the rest of the conversation. Health and fitness degree. So what was the intent there? What did you think you were going to do?
Yeah, I wish I had a really good story for that. But it's actually, and I'm not to let my parents not see this, but I literally initially, and everything has a reason, but I chose it because it was the only undergrad degree at Baylor that didn't require you to take a foreign language, which I just didn't want to do.
So it was purely avoiding
I went
foreign
through
language.
Back when you had to, so I went in there initially to avoid foreign language at all costs, and landed on, and I actually started as a broadcast journalist major. So my initial life dream was to be an ESPN sports center anchor. And obviously I don't do that. And so I got there, was in communications, and then was looking to do something different, and that's how I found it. And it really, though, God works in mysterious ways. Was there any interest
at all, though? Or I mean,
none. And so then I got into it, and God works in mysterious ways. I mean, all the dots connected, and it was a degree that was in flux, and it's actually called a public health or community health degree now. But it was a lot around fitness and health, but it was around public health and wellness, and we did a lot of work around how do you develop programs for folks to have better maternity care and prenatal care. And so it started to really become something that I enjoyed. And we had our scientific classes like kinesiology and anatomy and physiology. Did not enjoy that, but it allowed us to see that, and it allowed us to take business classes. So it started to bring in this idea of kind of what does public health mean, what does that look like, and then what's kind of the business aspect. And that really is what moved me more into like figuring out the healthcare space and going into it. So and really. What I realize now is it's what got me into value-based. Why value-based care always made sense to me is I have this base of there's better ways to just sort of take care of populations.
Yeah.
The problem is we have not known how to do that very effectively, and public health has struggled to try to boil the ocean instead of minimize. So got in there. Now, in the middle of it, I will say I had this grand dream of, growing my hair out really long and becoming owning a gym and being a personal trainer.
You thought, okay.
But as one of the girls I dated at the time said, nobody would want to have you be a personal trainer if they looked like you. So I realized that I physiologically wasn't made up to probably be the best salesman of my own trade. So went through that phase and then stuck with it, and then left there and got into a graduate program in healthcare administration, and sort of connected all the dots for me. So,
Now, did the Navy precede this?
No, the Navy. And thanks for bringing up the Navy.
We were talking the Admiral earlier.
No,
I know that's your big.
So David Robinson is my favorite NBA player of all time. I graduated from college, from undergrad. I moved to San Antonio where I was doing my graduate work, and started in August of 2001. And so I went up to class on September 11th, and I walked into class and everybody was gathered on the TV, and the towers were coming down, and there was confusion. And San Antonio, for those that are native Texans, is a fairly intense military town. Mm-hmm. And things started to get, as more came out, it started to get really intense. So I left and picked up the phone, and just felt there was something there I needed to do. And I called a Navy recruiter and I said, I understand what's going on, understand what's happening. Here's my challenge. I'm in a graduate program for healthcare administration. And she said, "You are in luck, sir. We do healthcare in the Navy.
Yeah.
And we actually have a scholarship program for people that are working on their graduate degree. So why don't you just come apply for that?" And so I did, and it was an incredible. So I got into the medical service corps. So the one thing that isn't cool is that I was in the medical field. I wasn't, my son's first question to me was, "Dad, were you a SEAL?" And the answer was a hard no. But I was in the medical service corps and I got into patient administration, but really had the privilege of going to National Naval up in Bethesda, which was interesting because it was in the height of the war. And if you were an injured sailor or Marine, then you had to be treated at National Naval Medical. So we had all of the troops and all the sailors that were overseas during Operation Iraqi and during Freedom. It was one of those moments that, I got to do what I got to do, and my job was, what it was, but it just gives you a ton of perspective.
Yeah,
I mean, to be able to walk a floor and, see, Doc Worley, who's an 18-year-old corpsman who, lost both of his legs to a bomb, and his view of life and his perspective, and you sort of walk back from that and you go, the fact that the cardiologist didn't sign their charts last week seems pretty low impact to what, we're doing here. And so it was a great chance for me to serve, you feel like what service meant, but also just to look at the world from a lens that says, no matter what we have in front of us, right, we can simplify these problems and we can solve them, but if we have to keep a level of perspective.
Yeah.
And the military has an amazing way to do that for you. So that was a great experience. I just, realized that.
Well, did it further ensconce your desire to go into the administrative side of healthcare in the private sector? Or?
It did, because unfortunately for the everything that's great about the Department of Defense and the military medicine is it's structured in a certain way. There's very little flexibility. But what I saw was this incredible ability for healthcare and healthcare systems and what we could do even in the Navy and what we could do for people. I mean, this is an incredible asset and that we have access to both in the United States but it's not perfect. And so how do we, and I knew the hospitals were a tough environment, even in the Navy. This was a kind of a dinosaur feel. So where's this going? But it was a lot of we got a lot of work to do here. We're doing some cool things. We can take a person who got hit with a bomb in Afghanistan, and in 23 hours we can have him in an ICU in the United States of America. That's an impressive deal, and we can save him and we can give him a life forward. That's the good news. Bad news is, we have other challenges. So, it really kind of let me see that perspective that it's never that bad.
Well, see, that's the perspective is good because sometimes there's this, I think, misconception that a system has to be perfect or otherwise you scrap it and start over, right?
Yeah.
And sometimes you see people that, especially young people that have this perspective of America, and if it's not perfect, then we need to burn it down and start over again. It's no, hold on. There's an iterative process. We can go about fixing things, but if the expectation is something has to meet an impossible standard, then we shouldn't have that impossible standard. We should accept that every system is going to have warts and lumps, and you should seek to correct some or specifically correct certain elements of it. But the system itself, the structure itself, doesn't need to be completely undone and start over.
Well said.
And so anyway, that was a little bit of my diatribe. But
No,
I think
it's
we'd
a great point.
see eye to eye there. It's like, I work in a very broken system. You and I both do, right? It's like, I understand that. I also know I can't boil the ocean, as you used terminology earlier as well. So, okay, what can I be a part of? Can I be a part of educating people in an unbiased way? Can I introduce self-funding to a new audience? I mean, okay, that's a minuscule impact to the overall system, but, I can sleep at night knowing, I have a relatively positive aggregate impact, even if it's on a minor scale. And okay, so be it.
Yeah.
One of my good friends, I mentioned David Voorhees earlier of True Captive. He's the CEO. He made a very good point, a very salient point the other day that I was hearing him talk, and he said, healthcare is always in flux. It's not broken. It's not fixed. It's somewhere in between, and knowing it'll never be fixed, but it's never completely broken as well. If it's in flux, what part can I actually work on?
Yeah, I think, healthcare, I've been intrigued and amazed by the time I've spent. I've been in different environments. I've worked with physicians directly. I've worked in health systems. I've worked in surgery center companies, and tried to just see different vantage points. And I think being in flux is again. But one of the things I've always tried to get myself around is how do I think about healthcare? And I'm kind of in this place where it's like I feel like healthcare isn't really hard. Healthcare is complex. And when I think about how do I then take that and figure out what that means for me? Hard things are difficult to find solutions for, is how I think. So if something is very, very hard, it's going to be hard, and it's going to be there, and we got to deal with it. If something is complex, we know probably what the solution is. It's just going to take a lot of hard work and a lot of thinking to navigate that complexity. And because of that, and it goes back to, then we have to think about, okay, how do we incrementalize that complexity to little wins that we can go through, which I think is, again, public health is not hard. It's easy to say things like everybody should have prenatal care. Well, I agree with that. That's a solution. The complexity is how do you get everybody in McLennan County and Waco, Texas, when I was down there, to do that. So then you start to walk through, and I think what our gut is telling us, or maybe some of our instincts are time, is to either A, believe that it's not really complex, it's just easy, and we've got the solution. And that is dangerous because
some people do want to paint in absolutes, right?
You do.
I've got the thing that fixes everything. Just talk to me and I'll sell you whatever product I got.
Right. And then the minute and we call them, right, complex patient or complex member has something event that sits outside of that, then we go back to pointing at the system. And so I would agree with David. I mean, it's this concept of how, and I think what public health gave me as a base was that issue of what's hard and what's complex. And if it's complex, then how do we start minimizing the variables we can, impact that which we do, and start taking our successes. And I think that's something that we talk a lot about. How do we just get that little success? We know that what we build is not perfect every time. We know that it's not this, but we know that some of these factors are better than they were.
Yeah.
So how do we just continue to focus on that factor is better than it used to be? That's good. Yes, we have work ahead of us. That's what makes healthcare complex. But the worst thing we do is go back and keep destroying the things that we do that are good.
Well, and I think because it's such a continual process that there is no end, where you can work in this industry for 50 years and there's still problems to solve, right? Like they're just new problems or more complex problems.
And they've all been doing it. And you've talked to any executive you talk to insurance executives that retired 20 years ago, and they'll talk about all the things that they challenge. Being in health systems and interacting with health system leaders historically, right? They talk about the moment when the DRG system came in. And, for me, which is just mind-numbing because it's always been DRG, but just when that system changed, when Medicare moved from cost plus, and they go, at that moment, we thought the whole world, healthcare was going to end, everybody was done, and magically, right, because we knew what the answer, we navigated that complexity and went on. And so, it's an incredibly adaptable industry. It's an incredible thing, but we do tend to always look back and go, okay, and so our challenge has been, more now around how do we get to this idea of truly getting people healthier? How do we get from a sick system to the well system? But how do you do that in a way that we have the economic complexities we do? And people want to jump to the end point, and I think that's where mistakes may happen, or like you said, certainly things get put in place and it becomes the thing, and then you wake up a little bit later and that thing didn't quite deliver, and it's because the system is going to be more complex than that. So we have to find ways to forge all that together.
Yeah.
generally in any company, when you're dealing with a complex solution, what you don't do is sit in a room and yell at each other. You usually sit down with all the stakeholders and say, okay, how do we start to draw that on the board? And that's really kind of the crux of what EHN is attempting to try to do, is say we recognize this complexity. We know what the problem is, right? We spend too much for healthcare. The quality is variable at best. We have a real challenge there. It's absolutely, what was it Bezos that said, or no, I think it was above, is the tapeworm of the economic tapeworm of society, and it's dragging things down. We get that, and so now we have to say, okay, how do we bring the stakeholders together? And I think we have to have an honest discussion about who the stakeholders are, and bring them together and start getting a dialogue around how does this stakeholder, the provider, how does this stakeholder, the member, how does this stakeholder, the employer who's financing it all, how do we start to sit together and figure out solutions, knowing that we're not going to make everybody, healthy tomorrow, but we're going to start taking, small wins. But the minute you exclude a stakeholder in a complex environment, at least from my perspective, then you've actually added to the complexity and you've started to erode results. And what I fear at times is that, and even like it, we poke it. Well, let's just exclude insurance globally. No, you can't. I mean, they have a role in the system. So you have to figure out how to deal with that. Let's exclude this. No, they have a role in the system. So how do we do it? So that's, what EHN has tried to do is kind of bring the stakeholders we can get our hands around together, starting with a very simple concept of an employer and a provider, and bring them closer together so we can start navigating the challenges and start to deliver the higher value healthcare, because we're saying up front, it's complex. And you have challenges, they have challenges. Nobody's immune to each other's. They get it. The part that I think gets lost is the healthcare systems or the providers in every community are also the employers. So same financial pressures they feel from you. They're locked in, or Aon or Gallagher or whoever broker's walking in and going, your costs went up 20%. Your complex patients are not engaging in care management. How do we get them there? So we're all in a clear understanding. Now we just have to start to figure out how to bring the stakeholders in.
Well, so I think that'd be a nice segue. Let's start talking about more of the solution side, right? Which is where I think EHN obviously aims to do their part in this. And so very briefly, let's describe what EHN is and what you guys do sort of as an umbrella.
Yeah, we like to call ourselves a health plan solution, but we build it on a foundation of a high performance network. So that is our core. We go into markets, we go into regions or communities, and we look for and partner with high-value health systems and high-value providers, and we do build out a network of care from pediatric to post-acute, every stop along the road. What we do in that, though, is we absolutely partner with and maintain tight partnerships with a set of providers. So we guarantee there will be every type of specialty available to you when working with EHN, but we will not guarantee that every specialist will be available to you when you work with EHN. And we do that on purpose. And so we do a lot of that in alignment with large network structures that have been created underneath value-based frameworks with the health systems. Call them an ACO, call them a clinically integrated network, but they have built relationships from pediatric to post-acute to help them manage the value-based environment that they're in today, or their value-based contracts. We want to follow that same path because now we know we've got a network, but we've got people who are used to looking at performance data. We have providers who are used to being held accountable, and we have providers who are used to trying to manage care in the lowest cost setting. And that allows us to really bring that. What we do is glue all that together. So a lot of times those networks are in a way they're between independent. They're going back to, it's a complex network because they're all individual tax IDs, and something has to glue them together so the employer can consume them. And that's what EHN walks in and does at the foundation. Then we build on top of that. We work on the clinical model and how do we align all the clinical space with the clinical environment. So if a health system is actively doing gaps in care closure with members, then we want that same activity to happen to the employers who might work with us. If they're actively reaching out to complex patients to try to help them navigate and work with their care plan from their primary care, we want to use that. Part of that's why would we reinvent it? And the other
I was going to ask you, so the name High Performance Network suggests that other networks aren't high performance. And not necessarily it's not disparaging, but you've picked the term high performance. So what makes it a high performance versus a performance network?
Because we do try to define the performance as the PMPM actually starts to level or go down, and quality actually starts to go up.
Right.
And what I would say is there's probably other networks that do that. I think they have a hard time proving it. So our goal is to say we're high performing and we're proving it.
We're proving, yeah.
And we're working on the care over time. And we're not as concerned about an immediate give on a discount or immediate give on that. We actually want you to show, we want to show you that this network of providers can actually deliver a sustainable result. And that's why we use that term high performance. You know, and also to kind of get away from the idea of narrow, because narrow sounds
well, I was going
like
to ask you, so is it or is it not a narrow?
Oh, it's a narrow, it's a limited, it's
Okay.
a defined. It's
whatever
definitely
euphemism you want to apply to.
We were in
It just
Orlando.
suggests it's not everybody, right? Which is what a
Correct.
network is in and of itself.
Correct.
It's not everybody.
Yeah, we were in Orlando talking to our partner down there, and they said they gave a stat. You know, Aetna has 13,000 providers in their environment. They have and they're of PCPs, I think, or some number, but they're 1/10 of that, right? So I mean, yeah, it's trying to level that out, and it's not as much always about trying to do it for some kind of horrible reason. We have two real goals. One is we do want to create value back to the providers that we work with, and one value that they have is can I move market share and opportunity and frankly they do get paid fee for service, some of that care to go through. That's the base level. What it really is about is I can't manage. So if Blake Allison is a complex patient and in a PPO environment, I can go as Blake, I can go to any provider I want, whenever I want, whatever I think I need. Mm-hmm. My primary care physician is going to have a really hard time navigating me through that process.
Okay.
If we have linked up Blake Allison to the primary care physician and we can say this goes into this bucket of specialists who are in your other relational, your programs with your other related programs, and it goes into this environment where your EMR connects into it, if we can keep them in there, then don't you have a better chance of managing them over time? And they would say, yes. They would openly say, part of the frustration with the payers is they're letting people go everywhere, and then their care manager is calling me and telling me I've got to do X, Y, and Z, and I don't have visibility into X environment or Y environment. Okay. Or they let them go to a different state because they're in some other program with X health system over in another state. Well, how do I know what always is happening through that? So a lot of it is around clinical rationalization, more so than it is immediate just network rationalization. And that's why we follow that ACO or CIN footprint, because they're used to managing care across a defined continuum. If we start to break that continuum up, we're just adding to the same, we believe, and our data is starting to show, we believe that that's going to go right back to the same problem we have.
Well, so kind of juxtaposing a traditional network versus what you guys are doing, right? So you lose a little bit of choice, but it's not necessarily choice in that it's just everybody, right? There's this infinite choice almost, right. It seems like. But in doing so, you can kind of coordinate that care a little bit better, but also the idea is higher quality providers that value itself, and that there's an inverse relationship with higher quality care and the cost being driven down. Correct?
Generally, there's two.
Generally, okay.
One, we do actually sometimes get good immediate price advantages.
Okay.
But number two, right, absolutely, as they manage the care over time, the high performance network, if we're going to call it that, has to see PMPMs start to sustain a more rational result. I think I stopped short of saying they're immediately going to go down, because that's, I think, the naivety of the idea that there's not, again, complex patients in an environment. Healthcare costs money, but certainly it should stop spiking, moving, going through. And we're also trying to create the relationship. So you the health system providers, mainly the physicians, we'll kind of leave that, but the providers have longstanding relationships with the patients who are the members of these employers. Generally, take turnover aside, employers have those people working for them for some period of time. The entities we've sort of introduced in the middle are the shortest term partners.
Okay.
People change insurance carriers. They change a lot of things. The employer makes different decisions. But the two long-term stakeholders, you, the employer who has these members, and the provider who's going to treat them, how do we keep that stuck together so that we can actually sustainably move things? Because when you make changes on, not so much in the self-funding, but if you were to change it from a blue to they all have different rules. They have some people aren't going to be a network that were yesterday, and we're just trying to keep that provider-member relationship close and then bring as much of that clinical work to that environment, because we want to keep it local, want to keep it sustained, and we want to keep it together. That way we wake up 3 years later and there should be better. If there's not, we have a path to walk into the providers and go, we need to talk about performance.
Yeah.
And that's that performance culture that they're doing through their ACO work around. We understand when the PM, when I first got into healthcare on the hospital side, we couldn't spell PMPM. Because unless you're the HR exec, that was not a metric.
Yeah.
Your metric was expense per adjusted occupied bed. It was admissions and adjusted admissions and volume and revenue. That was your currency. Now they're getting millions of billions of lines of claims data to look at these and they're saying, why is my Medicare population up in this area? Why is it down? How do we get better? We have an incentive to do that. So we're tapping into that culture and trying to, let self-funded employers also tap into that culture in a more direct way.
Okay. And so one of the things that we were having a kind of previous discussion, right, to get to know each other and get to understand the solution. One thing you said to me that I thought was interesting is that it's not necessarily, competitive to a reference-based pricing arrangement. There are situations where you guys can be kind of bolt on together, right? So could you describe to me how that would work?
Yeah, we found, reference-based pricing obviously had a lot of success, grew quickly, and for all the reasons we know why. And it did help bring this cost issue. But when we first got involved, we felt like that was some sort of, competitive environment. And we started to look at that and say, it was definitely as reference-based pricing was struggling in certain markets just to be able to continue to look at access. That's where we said, well, you have a huge role and a huge part of helping the health plans deal with care that starts to happen either outside of a network or out of network, or a provider that doesn't ever want to come in any network no matter who it is. And your ability to negotiate, price that, and deal with that's a huge, huge win for the plan. And so what if we found a way to say, in that local market, we can get, pricing that is competitive, a card that works, guaranteed access, no risk of balance billing, some of the things that that they've had some issues with as the providers sort of started to push back on it. What if we could eliminate that? But then you all can absolutely protect the plan from the out of network, from the out of area, from all the other things. And I think that that in some areas, not everywhere, but in some areas, that really became the best of both worlds. The plan is protected, and that methodology makes all the sense in the world to me when somebody goes to an out of network dialysis provider. I get it. Yeah, we're stuck as a network company trying to go negotiate that. It's tough. Using these companies that have gotten lots of muscle memory in that, it's hugely beneficial for the plan. So let's use it for what it's done, but then let's find a way to say, what if we had access to a network in the local market that would let people flow in and out in more of a traditional manner? And I think it resonated with some of them as well that said that's a nice combination.
Okay.
So we have found them to be, at times, and some of that's played out. Multiplan has acquired HST, which is an RBP platform. Multiplan's a network company, or has a network PHCS, ELAP, which is a very well put, great RBP company from that perspective. They did the acquisition and partnered with Imagine Health. So it's an area that you see the market sort of figuring out and coming to, and we're just, I think in that same
Well,
space.
and so that, I've kind of grown up in this world where you see the disparagement of the idea of the networks in general, right? Like,
Yeah.
I think it's some people want to point the finger, the bukas, and maybe it's kind of misdirecting people's attention towards something that's, they should be controlling the cost of care, not who gives the better discounts. But so why did we get along that path, do you think? Why did this idea that the network was a bad thing come to fruition? And, how are you guys offering sort of an alternative to that? Like, I'm curious to hear that.
Well, I mean, if you go back to the networks we all tap, and let's talk the Buka networks, which is generally what everybody either used on the insurance platform or used a lot of those rental Cigna networks or whatever through the TPAs in the self-funded space. Going back to that sort of the two stakeholders as the payers, if you will, the self-funded employers and the providers kept getting moved further and further away. And as the networks kept adding everybody just in or doing punitive work or doing punitive things, the face of the self-funded employer became Cigna to the provider, not Blake Allison LLC.
Yeah.
So they're looking at it going, well, last week you denied me a payment, Cigna. I'm upset with that. And oh, by the way, you let in all my competitors, so I have no advantage in this network. So I need to continue to fight you over pricing. And so it became about a provider against an insurance entity who's also, by the way, contracting for them for everything. So they're not just saying, I'm here to talk to you about the self-funded employer space. They're here to talk about their Medicare, Medicaid, they're fully insured. So you're figuring, I got to fight everything, because if I give too much discount, I'm going to hurt myself. So I'm got to go and compete. So the providers as they got larger, started to say, I've got to be able to react to the size of United, and I need to go press price, not because I want to hurt the employee, but because I don't get any advantage in the market because all my competitors are in, and you're all paying us the same. You don't steer to me, steer to anybody else. So I've got a built-in aspect of how do I gain market share? I don't. We all got in these networks because you told us they were a PPO network, and we discounted for steer, and you then let everybody in.
Okay.
So how do I then go back
Yeah.
and start to do it? And then as other as their economics were there, no doubt they turned to the commercial space. So it was more about, so what we do is say, you're not negotiating with like EHN doesn't make any more or less money whether you give us a 2% discount or a 200% discount. There's no game there. We're here on behalf of self-funded employers who want to align with you, and they say, well, if that's what I'm targeting, then I understand I need to give price advantages for those that are willing to be more advantageous to my network, and we hold out the other ones to coming in, and so they maintain that advantage.
Okay.
And so they were fighting BUCA, and the employers got caught in it, versus they were fighting the employer.
I see. Well, and so that's, it kind of goes back to that, what we were talking about earlier, is you don't burn the whole thing down and start over, right? There might be a better way to arrange a network, or maybe it was the original idea of the network just sort of redefined and redone 2.0. We got a big thunderclap, but that was pretty.
That was like
I don't know if that
God
caught
saying something. I don't know what we did.
Like, I swear,
yeah,
Blue
we
Cross,
didn't mean to.
don't
Lightning
come down
will
on me.
strike.
No, it's fine. We definitely need the rain.
We said BUCA on the lightning strike.
Yeah, there's got to be something to that. But so we don't have to go so far as eliminate the network altogether, right? Like there could be a better way to arrange it. This idea of the high performance, could be complementary to reference-based pricing. What about, kind of the bundle case rate type arrangement too?
Yeah, and that I think that where we haven't. So take the inch and the next inch and the next inch. I mean, where we today, because of ability, speed, rationality of where we are. I mean, we're building things on a fee-for-service chassis from a transaction perspective. You're absolutely right. The ability to keep evolving the payment structure inside that, because now the relationship is set. The network is, we know who our partners are. We have pricing built. We know who the employers will be coming in. Now we can start to tweak it and start to go, okay, how do we, what's our next evolution on total joints? Today we're paying it on a discounted fee for service. It meets a case rate, but it's a discount off of something. It's a percent of Medicare. But how do we get that into a 90-day bond? But now we're doing it from the place of, hey, these 20 employers in this market would like to talk about how they could do maybe some bundle payment, to which I think the providers are going to lean into that and go, how do I do it? When they give, I remember when I was working in this market in DFW, we were doing, and this has always stuck with me, we were doing a lot of value-based care with the traditional payers, and we had big attributions, hundreds of thousands of lives in these, and we were managing them on the value-based side, and we were showing data-wise that we were either minimizing or holding trend almost flat, right?
Okay.
So you're sitting there going, God, patting ourselves in the back, 2% trend, maybe flat, just really excited about that. And then you go engage the consulting community, and they would talk about, the 5, 8, 10, 12% increase that on a community rating fully insured that, Blue Cross passed over. And so then you're sitting there going, wait. We gave you discounts, right? That goes back to and then we managed that care for at least what we had to this flat. So, but then you're taking a premium to the market that's higher when we've shown, again, it was for our subset, but that seems to me that the other problem in that is that the providers don't handle the pricing to the market. And so they're saying, well, if you're going to go ask for a 10% increase from the employers, why would I keep my, even when I give you an advantage, I don't know that you're going to use it other than to get your own margin. And so you're also kind of eliminating that aspect of there is no margin in this, right? This is the employer's dollars coming to you. You are the provider, which is, if you want to go economic terms, right, you're the supplier.
Yeah.
This is the buyer. Everybody is in between this buyer-supplier relationship. Why?
Yeah. It's
their money to your delivery. And so I think that's also where, a lot of that mistrust came. And then it all kind of manifests itself in the network. And your point, then it started to say, oh, well, these networks then are not valuable. And it's because the network was the end point of a tool and an issue of a relationship between two parties who don't trust themselves. And then it was like, so now I've got to just burn down the network.
Yeah.
And I've got to go to this different element that took away your ability to do payment model variation and innovation. It took away your ability to, look at members and go, hey, if it says this on the card, you can get in. And if you get in, it's a contractual rate and things happen on the back. Nothing will happen on the back end, right? You took away a lot of the pros of the network because we ceded that over to a party that unfortunately created some mistrust with the supplier that it was trying to negotiate for on behalf of the employer. And
do you ever think we'll get towards, obviously you can get a cash-based price, right? If you go into an office and ask for, for a cash. So do you think we'll ever get that far? Or do you think that, is that not scalable to do that for everybody?
It's a great question. When I think about what's the next sort of item that I would personally like to see us sort of try to think through and wrestle, maybe not I'd like to get to where certain things like primary care, good primary care, defined, by metrics, but solid primary care is literally either paid for, prospectively through capitated type payment, and there's no more, transaction set. So you don't have to worry. Yeah, you don't have to worry, but doing that at scale, right? I mean, doing that in a way that says there's nothing that stops us, the network, from being able to pay our network partner through the TPA and through the employer a PMPM to do that, and we just turn off those bills. So instead of going to pay cash, why don't we make it almost transactionless?
Yeah.
Where you go, because all we need to do is get you into the right care setting. The counter to that was the high deductible health plan. Then everybody had to pay money all the time, and it created this potentially a moment of I don't want to go get any health care till I need it because I don't know how to do it. Well, how do we flip that over and say, I don't want you going to the ER. That's not good. But I certainly want to create a world where you don't even have to carry anything in your wallet to go to this broad set of primary care physicians or a broad set of providers where they know and they're trained towards trying to managing you the best deal. What we get asked is, well, how do you know they're managing? And that's where the data matters.
Yeah.
You have to get the claims data. You got to put it in a mechanism. We use the Milliman Med Insight tool. Be my one plug. They don't sponsor us, but maybe they should. We use Milliman's Med Insight tool for our own, and then we actually pipe the data over to the provider partner where they do analysis on it as well. So everything I'm saying is pie in the sky until there's actual performance monitoring coming on top of that. And that's part of our relationship with the providers, is know that we will have performance monitoring.
We can't manage what you can't measure. It's one of my favorite phrases, and it's absolutely true.
And as much as, but we want to engage you in the performance in a meaningful way.
Yeah.
Not come in and tell you all the horrible things you did last week. We want to come in and tell you where are the areas of opportunity for improvement, which, oh, by the way, a lot of the good ones are already out ahead of that, right? They've got big Medicare populations they're managing. They're already looking at reams and reams of data. We're just layering in ours.
Well, so let's bring this down now to the employer level, because I do want to talk about, if I'm a broker or consultant listening to this and I'm going, okay, we've talked a lot of the theory, but if I got a client that I want to see as a fit for that, what are some of the determinants of whether or not this would be an appropriate solution for an employer?
Yeah, so first and foremost is network fit. So we do a lot of work around what we call geo-adequacy or geo-access, whichever word you want to use. But first thing is your employer partner a good fit to be able to access the care they need in an EHN network?
Okay.
And we do a lot of analysis, and we can do that. And we do that with any of our consulting partners. Send us any zip code file you want. We'll run it across our national. It's a national footprint only in the sense of we got a lot of states, but it's not a national network. And we'll run that, and we'll go back and we'll tell you very clearly. We can cover 80% of that, 20, 0, 5, 10, maybe a good fit, may not be a good fit. So that's our first step. Is it just a good fit?
Is there a threshold of a percentage of coverage where it starts to make sense?
If you say I want to look at my 100 employees in Dallas, we would like to get that we can cover 90+% of them. Doesn't mean it's the provider they have today. It means they can get to the providers they need 90+% of the time, all the time. That leads to the second one is we got to look at disruption and know how disruptive that it may be. So, if you send us your 10s that are being used today, we will look at how many of those are in our networks, and we can come back with a percent that says here it is. And with a limited or narrow high performing network, there's going to be some, and that's there. If it's 100% not our network, probably not the best fit to start without a good conversation. But if it's up in the 50, 40, 50, 60% using ours, which you need to get, think about the next three. So we look at disruption, and then the last one is we actually reprice. So we'll take a claims file and if they're on TPA environment today, we have a data spec. We'll reprice all those claims as if they'd come through our network the year. And if we can't show you savings, then no,
Yeah.
we are a horrible solution for you. But I said, tongue in cheek, I mean, we should be able to show something. And if not, then we need to figure out why and figure out what's going on. Knock on wood, so far, all of our repricing exercises have generally delivered good. So those are the 3 steps of our kind of pre-sale we walk through with a consultant and say, here's how we're going through. And that leads to, you mentioned it, how do we set up a network strategy? Maybe do we need to use a wrap because there is a little bit too much disruption? Do we need to figure out some of their plans?
So obviously this is predicated on the notion you're self-funded or want to be self-funded.
That's right? Sorry. 100% have to be self-funded.
Yeah, okay.
We are not, nor intend to be an insurance company of any type.
Fair enough,
you have to be self-funded.
So your solution obviously is predicated on that, as well as the other components of a self-funded plan being chosen and put into place. So let's talk about kind of correlating vendors, right? Ones you coordinate very well with. You don't have to necessarily, it doesn't necessarily be a list of names, but it's kind of prerequisites for TPAs and stop loss vendors and things like that. When I'm an employer or a consultant trying to put together a replacement style plan.
Yeah, so we do have, I'd say the one area that we're the most engaged in as far as, figuring out our own path is how we accredit and work with TPAs. Mainly it's because of our model and the need for the data the way we talked about and the performance monitoring. We need some things to happen on the integration side that are not insignificant. Okay. And so to say that we can just grab any TPA that might be out, now I think they could all get there, but we would have to sit down and really understand why we would use that. So we do have a bucket of preferred partner TPAs that have gone through that process with us and are able to do it. The minute I say that, right, we get a prospect or something that comes and we ask questions. So we're going to be flexible, but we do have needs that have to be met from a structural perspective. On the PBM side, our real goal is to have it be a transparent PBM. Doesn't always mean that's the case. We don't sort of quote unquote mandate anything. We just think for the best of the employer, the pass through, which I'm sure y'all have had on these podcasts, the pass through fully trained, the PBM space is a huge driver of cost. We have, certainly partners that are already flowing data to us that we work with that we can certainly talk about, but mainly just let's rationalize that space. But we will let the consultants can place that if they want to. And then we have done a lot of work, sometimes I think more than I realize, with a wide swath of stop-loss carriers around understanding our network, understanding our contract DNA, understanding how we're doing, getting the pre-rating we need that when the quotes come through, you can feel comfortable. Now, we're not financially tied to any of that, but if someone is struggling to get a good stop-loss quote, we have some folks that we can absolutely have really leaned into some of those activities and understand our networks really well. So we have our biggest thing is, understanding our network, understanding that there's must-haves in that environment, and then we try to be, as flexible and as open to what the employer and the consultant wants to do. We just want it to deliver that result of the better cost.
Well, I mean, that's really what the proof is in the pudding for you, is actually delivering the savings and high quality care and savings simultaneously. Correct. Flattening the curve, if you will, or the trend line. I mean, if that's what you're there for at the end of the day, right? So stop loss carriers is really sort of quantifying that, or almost endorsing, right? A stamp of endorsement. This is probably going to work if they're pricing you versus the other arrangement. Seeing some savings on the premium side, on the aggregate factor side, then obviously you guys delivering on that underneath, and it becomes self-reinforcing, correct?
Yeah. And they give us a lot of good feedback when they don't like. The pre-rating is an important process for us because they also can pick away things or pick apart things that in our contract structures that give them concern. And it gives us the ability to talk about those sometimes, not always, go back and just engage with the provider on, these are some things that we need to tweak. We call it strategic pricing, not discounts, because we are conscious there's some things we might need to. The pricing might otherwise be okay, but there's areas we got to tweak. Okay. We don't just. We need the easy button would be come in and give us a gigantic discount across the board. It's not always that simple, so we try to pick our areas and give them the opportunity to kind of walk through a pricing structure with us.
So we're talking about pricing and discounts, right? But maybe oftentimes the RBP uses the referential of Medicare. Yeah. Do you guys have sort of an average for certain, even broadly, or for certain services as a percentage of Medicare for as a barometer?
Yeah, we do. We contract on a fee schedule structure, but we take, once we get our contracts done, we run an analysis that indexes them towards the Medicare percent. Okay. So it's a range on the inpatient, outpatient, and professional services that we can provide to the stop loss carriers, but also we provide to, if there's a question about it. So we do understand that lingo.
Yeah.
But we're very clear to say that if we say, 165 or 155 or 145 or what, that could mean something is in there at 185, but it could mean something else is in there at 105.
Right.
And, we're going to be very clear about that, which I think is not dissimilar to, what reference-based pricing, they're trying to get a number, but things fluctuate even in their environment.
Well, and they have discretion, right? On a single case, like if I can get it resolved for 175 instead of 160, and I have the authority to do so, I'm going to do it, right?
Correct.
Like because it gets it resolved. The longer these things linger, the less likely they are to close or they get more expensive.
Correct.
So I totally get that. So let's talk, kind of as we gradually move towards the end here, the future of this. You've been at EHN for a little under 2 years, correct? Or
actually over. I was I started in January of 2021.
Okay.
And, but as a consultant initially, and then came in full time. So I guess came in full time in October and CEO in July. So I'm just across my 1 year anniversary as CEO. So for us, I think it's a couple things on the really kind of separate. One, on the macro side, I mean, we are going to be thoughtful about where we grow. From a new market perspective, our kind of boundaries are, if we're in a state or operating a state, are there things we need to do in that state to give us more of a statewide presence? Let's close those first.
Okay.
So there's a few areas we're in. I'll use Florida as an example. We've got really nice partnerships in a couple markets, but we have some areas to focus. So we're going to continue to get our footprints, out a little bit wider, but really just to rationalize the regionality of what we do. So that's, always on my mind. And building networks is hard, and building networks is time consuming, and so we have to be mindful of that. I think on the other side is we bring employers in, from a what we go and where it's up. If I woke up 5 years from now, and we have a lot of lives running through, obviously we're proving our performance. So the measurement of that and getting really good at measuring is something we're always, and we need more claims data to be better at measurement. So
hey, it's the chicken or the egg.
As
right?
a young company,
problem,
that's
if
our
you will.
that's always something you have. But really underneath that, it's where you were going earlier. We know fully that we've got to continue to innovate on the payment model side. We have a unique opportunity to go from a fee for service, which builds in the frustrations we've all felt, which is the inherent amount of churn, and move that towards things like you mentioned. How do we do best primary care, but at scale? How do we do bundles in certain areas? How do we create? And I think that's on the most macro in the relationship. Our vision is to get to where the employer base and the providers in our markets are actually they're yoked together in risk. And we have a glide path in our relationship with our providers that says as we grow, we will come back together and move to more like some sort of a value-based payment model. Step one is sort of let's look upside, but as we grow past a certain life threshold, then we're going to talk about downside. And so all of our provider partners lean completely into it. And I think that's a little bit of a missing element out there is the providers understand the issues. They just have a really hard time engaging with the employer community directly. And they're willing to lean into that. And they're willing to say, yeah, if you're in my network and I can work with you and you've got mass in here as either a conglomerate or a large group and we don't deliver on the results, we owe you something back.
Accountability, right?
It is. Yes. And so that's always been eye-opening for me because, and really what I am fearful about is that the providers will push us to the shared environment and the value-based payments and the shared risk faster than the employers may want to get there.
I see. Okay.
Because it's going to bring with it, that means if they do well, you've got to pay that way too. Yeah. And that's not always easy to think through. Nobody likes the $100,000 invoice 9 months after the close of a plan year to pay. So that's a good thing and a bad thing. But I think the fact that the providers know and want to be accountable is something that
we're seeing some of the consultant market move to that as well, where they're actually putting their fees at risk if they don't deliver savings as well, right? I mean, there's risk, of course, inherent in that, but if I do well and deliver on my promises, obviously I'd be financially rewarded for that. But there's also the downside risk if I don't deliver too, which you could make arguments either way, but at least it's putting skin in the game for them strategy-wise.
Our counter to that is nothing, right? I mean, we stay status quo and we get frustrated, so we might as well start to really ask the question of, are we delivering a lower PMPM or a more sustainable PMPM, and if we're not, why not? How do we be accountable for that? So those will be our macro things as we grow in a community, is how do we continue to innovate payment And number two, how do we continue to move ourselves into a shared environment where we're equal yoking with the self-funded employers who own all the risk, and we need to find a way to meaningfully, share that.
Well, I like the way that you weaved in yoke. I think of the term yoked as like some guy that's really like muscular. We were talking baseball and Barry Bonds earlier. Somebody's being yoked, but I like that term, equally yoked. Last but not least, man, kind of closing thoughts.
Sure.
Obviously, Blake, we spent probably about an hour together, and I really appreciate you walking me through this journey. But anything you'd like to leave the folks that have stuck it out this long in the podcast, we'll see.
Yeah. So for the two people that are there,
I say that jokingly, but you'd be surprised. I know quite a few people that they listen religiously, and it's kind of cool. It's rewarding, but it's also, that tells me the people are kind of hungry for information, solutions. That's what I'm trying to position here. So closing thoughts of some people that have stuck around. I mean, I'm sure they're kind of going, all right, well, let's kind of wrap up. Where do I go from here?
Absolutely. Yeah. So, one, thank you, by the way, for letting me do this and being on. It's always fun to talk through it, and it's a great opportunity. So I really appreciate you putting all this together and being flexible at the last minute.
Yeah, man. Love it.
To go where we started, first I would say we are trying to build a solution. We think we have focused on trying to bring the stakeholders meaningfully together. We are not perfect. Not everything we do is going to be 1,000% the right way when you see it, but we have some really good fundamentals that I think will have value, and do believe and have data to show will bring value to the employer. So, one, I think you'll find that we're very honest in our approach, and we're trying to find ones that fit. If they don't fit, we understand, and that makes sense. So, to that, it means let us take a look. My ask would be, if you're in a geography where you've got self-funded employers and where we've built one of our networks, then send us some information and some data and put us to task. Let us prove to you that it could be a good solution, or let us not. And we are happy to tell you that it isn't. And we're going to fight hard when it is good to convince you that we're the right partner. So my ask would be just give us a few swings at the ball and let us make a sense. And I think there will be a few. Certainly some base hits and probably a couple of home runs in there for sure.
Absolutely, man. And at the end of the day, right, we're directionally moving this thing where it needs to go. And like you said, my software isn't perfect, but we're directionally moving the industry where it needs to be. And I think obviously, again, kind of setting that expectations in the real world of what we can do versus pie in the sky. Just understanding that this is a journey together. So I really appreciate you, Blake. It's a lot of fun. Always fun at the last second to get to meet somebody new that was outside of my network, right? My high performance network of guests. You're now in the high performance network, but really appreciate you, man.
Thank you.
And good luck for the rest of your week.
Appreciate it. Thank you.
See you, man.